All right, if you're gearing up for the PBC exam, you know just how important pediatric asthma management is. So in this explainer, we're going to break down all the high-yield clinical knowledge that you absolutely have to know, focusing specifically on infants and children.
Okay, so here's our game plan. We're going to start with the basics, what asthma really is and what we're trying to achieve. Then we'll walk through how it's diagnosed, the main principles of treatment, and of course, a deep dive into the drugs. We'll finish up by tackling those tougher cases, like severe asthma and acute attacks. So first things first, let's get the fundamentals down. Before we even start talking about medications, we have to be absolutely crystal clear on what's actually happening in a child's airways and what successful treatment really looks like. This is the foundation for everything that follows.
So what is it we're actually dealing with here? Well, according to GINA, the Global Initiative for Asthma, it really comes down to two key things. There's this chronic inflammation happening in the airways, and then there's airway obstruction that, and this is the key part, is reversible. This is what drives all those classic symptoms we see, like the coughing, the wheezing, and that chest tightness.
This is just so important. Our goal isn't just to make the symptoms disappear for a bit. We're aiming for total control. We want kids to be able to go to school, play, and sleep without any interruptions from their asthma. And a huge clinical pearl here is that last point. Pay close attention to how often they're using their reliever inhaler. If a kid is reaching for their SABA more than twice a week, that's a massive red flag that their underlying inflammation is not under control. Okay, so how do we actually figure out if a child has asthma? It sounds simple, but honestly, it can be really tricky, especially in the little ones where you can't always get those objective measurements. And here it is, a classic exam question. How do you diagnose asthma in a child who's under 6 years old? You can't just ask them to blow into a spirometer. This is where you really have to put on your detective hat. The diagnosis is going to rely almost entirely on getting a really good patient history and doing a careful physical exam.
So, when you're talking to the parents, these are the big clues you're listening for. A cough or a wheeze that actually stops them from playing, especially one that gets worse at night. That's a major sign. You also want to look for that classic atopic march, other allergic conditions like eczema or food allergies. A family history of asthma adds even more weight, and a history of a bad RSV infection is a really important piece of the puzzle.
A huge part of making a diagnosis is ruling other things out. So, on a physical exam, sure, you might see signs of atopy, like a runny nose, that points towards asthma. But you have to be vigilant for red flags that suggest something else entirely. For instance, if you see nasal polyps or clubbing of the fingers, your mind should immediately go to cystic fibrosis, not asthma. Now, while the patient's story is key, we always try to get objective proof when we can. For kids over 6, spirometry is the gold standard for measuring their lung function. For that tricky 3 to 6-year-old group, there's a newer tool called impulse oscillometry that can be really helpful. And then we have tests to find the triggers, like allergy testing, and checking blood eosinophils, which becomes super important when we start thinking about advanced biologic therapies.
Okay, so we've got our diagnosis locked in. Now what? Well, management is way more than just writing a prescription. We have to think about education, helping families avoid triggers, and this one is huge, making absolutely sure we pick the right inhaler device for the right child.
If there is just one thing you remember from this whole section, make it this. Think of an asthma attack like a fire. The bronchospasm, that immediate tightness in the chest, that's the flame. A SABA, your blue reliever inhaler, is like a fire extinguisher. It puts out the flame right now. But the underlying inflammation, that's the smoldering embers. If you only ever put out the flame, the fire's just going to start up again. To truly control the asthma, you have to cool down those embers with a daily anti-inflammatory, and that's the job of the inhaled corticosteroid, or ICS.
Look, a great drug is totally useless if it can't get to the lungs. In kids, this means device selection is everything. For babies and toddlers, the standard of care is a PMDI. That's your typical puffer, used with a spacer and a mask. As they get older, they might be able to use a dry powder inhaler. And here's a massive clinical pearl. During an asthma attack, a puffer with a spacer is just as effective as a nebulizer. That's a game changer. Just remember, for the littlest kids, we often have to use higher doses to compensate for the fact that less of the drug actually makes it where it needs to go. All right, time to dive into the pharmacy. We're going to systematically break down each of the major drug classes, looking at how they work, where they fit into therapy, and the key pearls you're going to need for both your exam and your practice. Let's start with the undisputed champion of asthma therapy, inhaled corticosteroids. These are the absolute cornerstone. They don't just manage day-to-day symptoms by reducing inflammation, they also prevent something called airway remodeling. Think of it like long-term scarring inside the airways. It's permanent damage that we want to prevent at all costs.
Okay, this table is pure gold for your exam. Seriously, this is where you can quickly see the equivalent low dose for all the common inhaled steroids broken down by age. So you can see right away, for example, that fluticasone is more potent, so you need a lower dose to get the same effect as budesonide. The main takeaway here is that most kids can be really well controlled on these low doses, and that's always our goal.
As a pharmacist, you are going to get asked about side effects, especially from worried parents. The local ones are easy to manage. To prevent thrush in the mouth, just use a spacer and have the child rinse their mouth out after each dose. Now, systemically, the big one is growth. You need to be ready to explain this confidently. Yes, there can be a small, temporary dip in growth rate during that first year of use. But the data is very clear. The impact on their final adult height is tiny, maybe 1 to 2.5 centimeters. The risk from poorly controlled asthma is so much greater. The mantra is always, use the lowest effective dose that keeps them well.
Now let's talk about the rescue inhalers, our SABAs like salbutamol. Their job is strictly for on-demand, quick relief. Going back to our fire analogy, this is the firefighter that puts out the immediate flame, not the fire marshal who prevents fires from starting. And remember, how often it's used is that critical, vital sign. If they're using it more than twice a week for symptoms, that's a clear signal their controller therapy isn't cutting it.
Next up are the LABAs, like salmeterol and formoterol. These are great add-on therapies that provide longer symptom control. But, and this is a huge safety point you have to know, they must never, ever be used by themselves for asthma. Using a LABA alone can mask worsening inflammation and has been linked to very severe outcomes. That's why they're almost always prescribed in combination inhalers with an ICS, which basically forces good practice.
So what about the LTRAs, like montelukast? Well, they definitely have a place, especially for kids who really struggle with using inhalers, or as an add-on therapy. But here's the key comparison to remember. If a child is already on a daily inhaled steroid and is still having symptoms, the evidence is pretty clear that adding a LABA will give you a much better result than adding an LTRA. This is an absolutely critical safety alert. Every pharmacist needs to have this top of mind. Montelukast carries a boxed warning for serious neuropsychiatric side effects. We're talking about things like agitation, aggression, depression, bad dreams, and even suicidal thoughts. It is our job to counsel caregivers to watch for any of these changes and to call their doctor immediately if they see them. Now, for those kids with the most severe, difficult-to-control asthma, we have some incredible tools called biologics. These are absolute game changers. This table right here is your exam cheat sheet. You can see exactly what each one targets. Omalizumab goes after IgE for allergic asthma, mepolizumab targets IL-5 for eosinophilic asthma, and so on. Make sure you know the specific targets and the minimum age for each of these drugs.
So what do you do when a patient just isn't getting better, even though they're on standard therapy? It's really tempting to jump to the conclusion that they have severe asthma and need a fancy biologic drug. But wait, before we go there is a critical troubleshooting checklist we have to run through first. This checklist is really the pharmacist's bread and butter. Before anyone even thinks about adding more drugs, you have to go back to the basics. Number 1, are they even using their inhaler correctly? Number 2, are they actually taking the medicine as prescribed? 9 times out of 10, the problem is one of those two things. Once you've confirmed that technique and adherence are perfect, then you can start digging for other issues like hidden allergy triggers or even questioning if the diagnosis of asthma was correct in the first place.
Okay, let's switch gears to the acute side of things. What to do when a child is having a full-blown asthma attack. This is a pediatric emergency, so we need to know the protocol inside and out. Let's walk through it, and then we'll finish up with some quick high-yield tips. This algorithm right here is our playbook in an emergency, so let's follow the path. Every child starts at the top, aggressive treatment with high-dose SABA and oxygen. Now we hit a decision point. If they're getting better, great, we follow this path. But if they're not improving, we immediately move to this next box. Add aprotropium and start systemic steroids. And if they're still really struggling, that's when we're down here considering IV medications and a potential admission to the ICU.
So when that algorithm says give systemic corticosteroids, what does that actually look like? Well, this table breaks it down for you. For most kids, we can use an oral option like dexamethasone or prednisone. But for the sickest kids who need an IV line, we'll use something like methylprednisolone. For your exam, you'll definitely want to be familiar with these drugs, their routes, and especially those maximum daily doses. Of course, the best way to handle an asthma attack is to prevent it from ever happening. This algorithm shows our long-term step-up approach to therapy. You see here at the beginning, for very mild, infrequent symptoms, just using a reliever as needed is okay. But as soon as those symptoms become persistent, we're at step 2, starting a daily low-dose ICS. If that's not enough, we can step up by increasing the dose, and if that still doesn't work, that's when we add a LABA. The whole idea is to find the lowest step on this ladder that keeps the child's asthma well controlled.
All right, let's wrap this up with some super practical, high-yield tips. Number 1, make sure parents understand that controller inhalers are a marathon, not a sprint. It can take months for them to have their full effect. 2, with a spacer, those first few breaths are the most critical. 3, if you can, switch a child from a mask to a mouthpiece around age 4 or 5. It gets more medicine to the lungs. And finally, never ever assume their inhaler technique is good. Check it and then check it again at every single opportunity.
So we'll leave you with this question to think about. After everything we've just covered, what is the one single change you're going to make the next time you counsel a parent about their child's inhaler technique? Thanks so much for joining us, and best of luck on the exam.